Welcome to today's webinar, Hypervigilance and Anxiety in EoE Patients. It's my pleasure to introduce Dr. Tiffany Taft. Dr. Taft is a clinical psychologist and associate professor at Northwestern University's Feinberg School of Medicine. There she researches the social and emotional impacts of chronic digestive diseases. She has a specific interest in the impacts of EGIDs and other esophageal conditions, as well as developing brief, accessible treatment for those patients who need help coping with their illnesses. Dr. Taft created the now official measure of the health-related quality of life for adults with EoE and published the first studies on disease stigma in EGIDs. She currently focuses on the role of the brain-gut connection in esophageal diseases with the goal to improve symptoms and quality of life in patients with these conditions. So without further ado, I will hand things off to Dr. Taft. Thank you so much for joining us today.
Thank you so much for having me to talk about this topic, and I look forward to sharing some of this new information and hopefully answering some questions about what we go over today. So I'm going to go ahead and share my screen. Okay. So my talk today is looking at something that is inherently protective in our human existence that can sometimes turn into a problem. So these concepts of hypervigilance and symptom anxiety are useful to a point, and that's how I'm going to kind of approach things today. My disclosure, my only disclosure is I own a private practice on the just west of Chicago, where we have we work with patients with EoE and other chronic digestive diseases. So as was mentioned in my introduction, I am a clinical psychologist since around 2009, associate professor at Northwestern, also the director of psychogastroenterology research. That's a long tongue twister word, but that is our term now for the integration of psychology into gastroenterology and digestive illness. And I was diagnosed with EoE in about 2016. So we joke around here that I picked it up from doing my research because I've been researching EoE since about 2010. Okay. So first I want to define some of these things we're going to be talking about. So hypervigilance is when the brain becomes overly focused on something going on to the point it becomes difficult to shift your attention to anything else. And so this color code of awareness chart I thought was a nice way to kind of break down the levels of awareness in our surroundings. So white, completely relaxed, not really preparing for anything, just feeling, you know, good, not really on edge or anything like that. Yellow, I'm relaxed, but I'm starting to be more alert, paying more attention to what might be going on around. So I think of this as like here in the Midwest, we get lots of thunderstorms, right? So it's like, oh, the clouds are kind of starting to look, you know, a little bit ominous. So that's kind of yellow. I'm paying attention, but I'm not really alert or worried about it. Orange, I start to feel a little bit more in a heightened state because something isn't looking right. Maybe those clouds are looking a little bit darker. Maybe there's some rotation going on. So that takes me into orange. And then red, I'm ready to fight or run away. A verified threat, it's time to take action and I need to do something to solve it. So that would be like the tornado off in the distance that I can see. So in a non-EoE example of our bodies, not maybe weather, is if you've ever put on a boot, one that's got lots of laces, perhaps a ski boot if you like to ski, and your foot starts to itch. And if you focus in on the itch, does it make this feel more intense, especially if you can't immediately scratch it? Like focusing in, it's like, of course I'm going to pay attention to it. And then I'm driving my car, so I can't really take the boot off. So then how do I start to feel when I can't scratch that itch? And if I try to distract myself, sometimes that works, sometimes it doesn't. But the reality is the itch is there. It's not something my brain is making up. And I'm paying attention to it because itching is not necessarily pleasant. And I want to get rid of it. My goal is to scratch my foot, but it's difficult for me to get at that right now. So that is an example of the brain directing its attention to focus on a sensation in the body that pretty much everybody, I think, can relate to. So what's really going on is a lot more complicated. So when we're in a hypervigilant or anxious state, paying attention, to those colors, I'm more in the orange on that scale. Something called the limbic system in the nervous system is engaged, and that is the second picture down at that process flow across the bottom. And the limbic system, the best way to think about it is we call it the reptilian brain, because it exists in reptiles. But unlike reptiles, we have all this larger parts of the brain on top of that. That's our thinking, making decisions. All sorts of stuff happens in our brains that don't happen in our lizard friends. But these structures exist in our brain, and they're in charge of involuntary things like temperature, if I feel warm or cold, appetite, sleep, and then also memory. Hippocampus is involved in memory. So these things are not things that we're controlling on our own, but they do interact with that thinking part of the brain. So we react to based on stimuli or sensory informations first. So I may see something, hear something. If it's internal, I may sense it or feel it, maybe feel something uncomfortable in my chest. That is processed first in the brain. And then the prefrontal cortex gets messages from the limbic system in about 1/1000th of a second. And then we start thinking about it. And we can consciously make sense of what's happening, if we're safe, if this is something I need to pay more attention to. And when you're living with a chronic condition, and I think EoE is a little bit more affected by this, again, normal process, because some of the symptoms are of like a choking sensation, which can be, immediate red zone, right? If I think I'm choking, I'm going to go to that red zone very quickly. So I think, unfortunately, EoE is a little bit more susceptible because of the nature of the symptoms. You have to consider a lot of other things. We have our hypervigilance and symptom anxiety, but how severe is the condition? What are your past experiences, not just with illness, but just in general in life, your cultural background? Do you have any prior traumatic events in your life? And what has it been like interacting with the healthcare system here? I've been a patient for a long time, and the system has gotten gradually more challenging, which adds on to the things that we need to consider when thinking about hypervigilance and anxiety systems. So I feel like the word anxiety can be problematic sometimes, because when I say anxiety, it's often that I'm talking about like pathological anxiety, but really worry or anxiety, pain, discomfort, potentially having a food impaction or any other signal from your gut to your brain that something is wrong is completely normal and expected. When we talk about this, we're on a continuum, not all or nothing. So you're either anxious or you're not. And honestly, it would be a little bit strange if you were experiencing symptoms of a food impaction and you didn't at least worry about it or pay attention to it. And then depending on our individual backgrounds, that worry can go from I'm a little bit concerned to, I'm freaking out, I'm having a panic attack because I'm feeling those sensations. And it will be different, not just between people, but within a person. Sometimes the situation will be manageable and other times it will not. So some people also don't worry when they really should be. People we are concerned about in our practice here at Northwestern, then we have people worry when they maybe don't need to worry as much as they might be. So this is what we're talking about when I'm talking about anxiety, not generalized anxiety disorder or other psychiatric diagnoses. This also does not mean symptoms are all in your head. This is the thing that I hear from people that are really concerned when we start talking about anxiety, that, oh, well, that means maybe this isn't really happening, or maybe my doctor might think I'm overreacting. Absolutely not. That's how we think about this, but the brain is absolutely involved. So technically it is happening up here, but the all in your head connotation that has the stigma associated with it is not how we're thinking about these things. So you may have, if you've been reading up or watched some other webinars or things on the brain-gut connection, this might be something you've heard of. And so that limbic system that I talked about is wired directly into our digestive system. So hypervigilance and symptom-specific anxiety kind of act directly on this system. And so the limbic system is wired into the vagus nerve, which over on the side where there is the stomach and the esophagus, you can see the vagus nerve and how it wraps around the esophagus. So while the vagus nerve communicates to the entire digestive system, you can see how our esophagus might be even more prone to this. So if I'm feeling anxious and I'm keying up my limbic system, it's sending signals down through the vagus nerve to the digestive system that it might be time to stop working on digestion. Unfortunately, those signals often amplify things like pain and discomfort. That's been shown not just in digestive disease, but in all sorts of chronic pain conditions. The sensation of butterflies in your stomach, that we all have if we have EoE or not, that is the limbic system talking to our digestive system. Why? That's how it's supposed to be. That's how we were designed. And unfortunately, when hypervigilance and anxiety get to be too high, it can exacerbate symptoms, make symptoms worse, which then also goes back to the brain and causes more worry, because why am I feeling this way? This is really uncomfortable, and it goes around in a cycle. So why is this important in EoE? I mean, many reasons, and not just the ones that are listed here, but EoE is chronic. It's often triggered by what we eat. Like I said before, there's this symptoms where it feels like food is getting stuck, and depending on where, it may feel like you're choking. Food impactions can be medical emergencies if they don't resolve on their own, right? You need to go to the emergency room and have somebody remove the food impaction if it doesn't resolve. We go through a lot of procedures with EoE, right? Especially early on when maybe you're trying to identify your food triggers. If you decided to do that, that can result in like 6 or 7 endoscopies in a year. I mean, that's a lot. We have limited treatments right now. And also the research shows, and maybe you've experienced this, that our symptoms don't often correlate well with endoscopy or maybe what the pathology says. So oftentimes people will feel great and they might go in for a routine monitoring, and their eosinophil count is off the chart and their esophagus looks terrible, but you're like, I feel fine. And then the opposite can happen. You can feel awful and your endoscopy looks normal and you have no or low eosinophil count. So we see that about 45% of the time, that they just don't jive. That's in the research literature. I don't know if it's higher in clinical practice, but in research studies, this is where we see a pretty decent disconnect between the two. So we developed this esophageal hypervigilance and anxiety scale, or the EHAS. And there are 2 subscales on it. And you can see the questions that we're asking on this questionnaire. So the research I'm going to present in a little bit is using these 15 questions. So the first 9 are looking at anxiety about symptoms, and the last 10 through 15 are looking at hypervigilance, or that extra awareness and attention being paid to what's going on in the esophagus. This is not an EoE specific questionnaire. We have given this to patients with all sorts of esophageal conditions here at Northwestern as part of their standard of care. We give this questionnaire throughout people's treatment. So we did look at this in patients with gastroesophageal reflux disease, which can co-occur with EoE or is sometimes a rule out in the beginning of an EoE workup. And so there are two papers. One came from our group and one came from a group out of China, looking at what parts of esophageal hypervigilance or anxiety might be important in GERD. And so what they found in China was that reflux symptom severity and psychological stress were associated with higher levels of hypervigilance and anxiety, but the acid reflux burden or mucosal integrity, which are two things measured via objective physiological testing, were not. So the EHAS was explaining symptoms reported by the patient and also other psychological distress, but the physiological data that they were collecting did not. And then in our study, this is actually a doctoral dissertation by Livia Guadagnoli, looking at esophageal hypervigilance, and again, seeing that it persisted across patients regardless of acid burden and symptom index on those pH testing that we do with people. So hypervigilance specifically should be considered in GERD. We also looked at this in patients with motility disorders. So maybe you've undergone an esophageal manometry as part of your care. A manometry measures how well your esophagus pushes stuff down into the stomach. So we found across multiple conditions where motility is affected, things like achalasia, hypercontractile, where the esophagus is kind of spasming, ineffective esophageal motility, and even normal folks as well. We found that esophageal hypervigilance and anxiety again predicted dysphagia or difficulty swallowing severity, where the high resolution manometry, that's what HRM stands for, were less important. So another group of patients where we're seeing this. So the reason I'm showing you this is to say that this is not unique to EoE at all. So the most recent study, I think what got me invited to come talk with you today, is looking at this only in patients with EoE. I should caution a couple of things here. This is a pretty small group of EoE patients, and we are a center where people come for EoE treatment, right? They may have not done well out somewhere else. You know, we have dedicated EoE gastroenterologists. So this is a biased sample. It was about 110 patients. So not a small amount, but certainly not the largest we've seen. So we again found that hypervigilance and symptom anxiety were the most important predictors of dysphagia and difficulty eating, and also health-related quality of life. So our conclusions from that study is that, again, clinicians should assess hypervigilance and anxiety, especially in patients with poor health-related quality of life and symptoms that, when we say refractory, we mean that's that scenario where the esophagus looks pretty good, the eosinophil count is low, but patients are still having a lot of symptoms. So we didn't find any difference between these two constructs between men and women. They scored very similarly. Where females scored actually a little bit lower on hypervigilance, but basically equal on anxiety as men. This graphic on the other side is me trying to show how we do statistics. So what I did is I took a lot of different things or variables to consider. There's something called the EREF score, which is a standard way to score how your esophagus looks in terms of swelling, rings, furrows. If you have a stricture, you get a score from that the gastroenterologist comes up with. The anxiety and hypervigilance. We also put in the number of eosinophils per high power field. And some patients had undergone something called an endoflip, which is a fancy way of evaluating how, again, your esophagus is contracting. So it's like the high resolution manometry, but even fancier, and it's something that we have here at Northwestern. So what did we find? So we looked at dysphagia symptoms severity, and I had to look at anxiety and hypervigilance separately because they're pretty related. So that's why there's two pie charts. So on the left side is anxiety and on the right is hypervigilance, both in blue. So we were looking at what predicted somebody's score on a questionnaire about dysphagia. And in both of these scenarios, anxiety and hypervigilance predicted that. And we put in all those other things, right? How the esophagus looked, the pathology. So those were also considerations, but they were not nearly as important. So 45% of somebody's dysphagia symptom severity score could be explained by symptom-specific anxiety. So if it was out of 10, 4.5 points of that would be from symptom-specific anxiety. And then also hypervigilance was important, but less so, almost half. So only 25% was attributed to hypervigilance. So it started to show that anxiety about symptoms might be more important in EoE compared to GERD, where we've been seeing hypervigilance is more important. What else did we find? So we also gave a questionnaire that shows pictures of different kinds of foods and says, how much trouble are you having swallowing these foods? So things like French fries, meat, pudding, so various textures, getting harder to swallow, rice, things that are difficult to get down. On this, it wasn't as important, anxiety and hypervigilance, but still, again, we found that they were the most important predictors. So 27% of the score attributed to anxiety and 10% attributed to hypervigilance. On my graphs where I say other stuff, the pathology, the eosinophil counts, the EREF score, those are in there, but a lot of other stuff that we just didn't measure is also in there. And that goes back to, I think, all the things we need to be considering, culture, prior experiences, medical system experiences, trauma, things that even weren't on my slide, right? Everybody is bringing a unique experience to the table here, and we just can't capture all of that in research. So this is oversimplifying something for sure. And if I had all that information, this pie chart might look a little different. We also looked at health-related quality of life, which is right now has been added as a standard outcome to be measured in like clinical trials for new medications, for example. So this is a really important thing that we're looking at. The FDA has mandated that we look at health-related quality of life, not just symptom improvement. And this really encompasses the social, emotional, financial, occupational, functional aspects of your life that may be affected by an illness. So we looked at how did anxiety and hypervigilance and also dysphagia symptom severity predict quality of life. And again, we see on the one side, anxiety was the most important where dysphagia severity was a little bit important. And then again, we have all that other stuff that we didn't necessarily capture. The physiological data was actually not a factor whatsoever. And then hypervigilance, about half as important as anxiety again, but dysphagia severity got bigger, which happens sometimes with these statistics, and then other stuff again. So then we wanted to figure out, if we could, what might predict symptom-specific anxiety. And the only thing that came out, again, all that physiology data was not really important, but if the person had had a food impaction, and the number of food impactions that they may have had in the past, I think we looked at the past year, and that accounted for about 5% of the anxiety score. So 95% of why someone might have symptom anxiety is explained by other stuff. And I think that is one of the questions that I need to answer or try to answer is, why does this happen? And are there ways we can help patients, intervene so that the anxiety doesn't overcome and take over their life sometimes? So we need to know what that 95% is. Same thing was with hypervigilance, but interestingly, a little bit backwards. We found that patients who were using a proton pump inhibitor, or PPI, which is used for reflux symptoms, reduced hypervigilance, but only 4% of the score. But if you think back to the GERD studies that I mentioned, those are reflux, right? The tense stomach coming up, feeling like a burning sensation. So if hypervigilance is important in GERD, taking a PPI would reduce hypervigilance. And some patients with EoE also have GERD, or they may have some reflux symptoms or burning symptoms. So this kind of makes sense when we look at it in that context. But again, we don't know 96% of why somebody becomes hypervigilant. So what does this mean for me as the EoE patient? How much attention your brain pays to sensations in your esophagus can potentially amplify symptoms. It doesn't mean that your symptoms aren't real, but it could mean that if you weren't as hypervigilant or worried about the symptoms, maybe they would be a 4 out of 10 versus a 7 out of 10. I'm pulling those numbers out of the air. So it's an amplification or a turning up of the volume of the symptoms, not necessarily creating them. So those two things, the attention and the worry, kind of can work together. But some people are hypervigilant without being anxious, so it's complicated. How your brain is interpreting those sensations in your esophagus is really important to consider in your quality of life. And more important to consider than how bad your EoE might look on testing. The testing is absolutely critical in managing EoE. I'm not saying that we shouldn't be doing testing, but if we're looking at quality of life, that might not be as important as these issues of how your brain is interpreting things. Our goal here is not zero attention paid or zero concerns about sensations in your esophagus. Like I said, there's a healthy balance here that we're trying to achieve that will be different for each person. The first step, though, is if I don't know if I have a problem, I can't fix it. So becoming aware if there's a problem. So this is a short form of the EHAS, and we suggest a score greater than 13 is indicative of what we would call high levels of hypervigilance and anxiety. So I want to leave this up for a little bit. Maybe you want to try and answer some of the questions. If you're in the somewhat true or very true column for all or most of these questions, then that would suggest you're on the more hypervigilant and or anxious side of paying attention to your EoE. And does that mean it's a problem for you? Not necessarily, but usually if I'm paying a lot of attention to what's going on here, I'm not really able to engage in or enjoy things, or focus. Concentration, anxiety is terrible for concentration. So it might be bleeding in areas that you might not even be aware that this might be happening. A lot of times this stuff happens behind the scenes and we're not really focusing on it and thinking about it, but our brain might be doing some of this. So things to look at are you keeping track of your symptom levels. Obviously that makes sense early on when you're getting diagnosed, but if you've had EoE for 7 years, how necessary is that to a very specific degree? As soon as you wake up, checking in with your body, that's a big one. Believing there's nothing you can do to reduce the symptom intensity. They're terrible. Things are never going to get better. I'm afraid if I feel symptoms in my esophagus. I'm aware of any temporary changes, and they're just awful. This just sucks. So those are the items on this short form that we're letting doctors use. We're pushing it out for people to use for free as a screener to help them understand what might be going on with their EoE patients. So once I realized, geez, I might be doing a little bit of too much paying attention here. Sometimes simply knowing that that's happening is enough to okay, let me correct this. A lot of people have skills to change this that don't require someone like me. Many people benefit from self-guided anxiety treatment via an app, a book, other materials on the internet. This is one of the nice parts of the internet. There are wonderful resources out there. Some of the apps are great for just doing something as simple as, no, actually it's not simple, it takes practice, diaphragmatic breathing. So things you can definitely try on your own that will help tune down that anxiety and that connection between the limbic system and the esophagus. Doing diaphragmatic breathing or other relaxation exercises, even going for a walk outside on a pleasant day, reduces the activity in the limbic system. So our friends in other areas of neurology and neuropsychology look at that stuff, not in the context of EoE, but just in the context of how the brain works. So we can already dial that down, maybe with some things we've been doing, but maybe we haven't been doing more recently because of obviously the pandemic, or we've become a little bit more wrapped up in other things that we're not doing those self-care activities. If these methods don't work, then I would consider seeking help from a therapist, preferably one who understands chronic medical illness. Having a therapist that understands or knows EoE is the best case scenario. There are not very many of us. I wish there were. We are working on that still, but it's been slow. But the good news is there are a lot of therapists who specialize in chronic medical illness or behavioral medicine or health psychology, as it's called. They would be pretty well equipped to help an EoE patient, but they would need some education probably on the illness that they could do on their own, or you could help them understand. Things that perpetuate these problems of hypervigilance and anxiety, again, checking in, how am I feeling today, as a means to prepare for navigating the day. Before you eat, do you have thoughts like, I hope this doesn't get stuck, or what if I have an episode and people see it? One of the things we learned about in our EoE quality of life is having a choking episode out in public. Again, maybe not as much of an issue these days, or over the past year with the pandemic, but being out in a restaurant, at a business dinner, and oh my God, if I have to go to the bathroom and get rid of it, as people say, that can be very anxiety provoking. What if people see it? What if people are scared by it? What if people think I'm choking? All those things, those what if questions. How much time per day on average do you spend with Dr. Google? I think every patient should be educated and informed. That's how we advocate for ourselves. And then you can go down those dark holes where everything's terrible, and it isn't for everybody. People who are obviously doing worse may gravitate to posting information online and telling their stories because they want to process them. They were really bad. But if that's all you find on your Google search, you're not seeing the other side of it, that's going to cause anxiety. And then lastly, have you established really strict routines around eating, or other ways that you manage your EoE. You know, food reintroduction can be really tough sometimes, especially if the food is potentially causing symptoms. So am I being really rigid about this? Because that's hard to maintain. You know, this disease revolves around food, and American culture revolves around food. It makes it really tough. So thinking about, am I doing any of those things? Some potential resources to find somebody if you want help, or the last one, the Anxiety and Depression Association of America has reviewed apps. There's so many mental health apps, and some are great, some are, you know, none of them are really validated to treat anxiety, but they can be helpful. And I thought the ADA's list was pretty reputable and good. So you can check that out if you want to narrow it down. The Rome Psychogastroenterology Directory is out there. You can search by your area. There's only about 400 people in that directory, maybe 500. So it's not a lot. So if you're not near a large city, it may be difficult, but a silver lining of COVID is telemedicine. So if I'm in Chicago, I can see somebody in the very southern tip of Illinois via telemedicine. So it has been a good part of the pandemic that is being paid for by insurance most of the time. So Psychology Today will give you more therapists trying to find someone, like I said, specializing in chronic pain or chronic medical illness. They should write that specifically in their bio. So to summarize, you know, we evaluate EoE in a lot of ways. We go through a lot as patients. And I think we really need to consider hypervigilance and feeling anxious more so about symptoms and how our brain is interpreting the gut signals. Again, no way implies anxiety causes symptoms or that they're all in your head, but we really need to acknowledge the role our brains play as the control center of our body. They are our computer. And of course, it's going to process information. It has to. This idea that the brain and the body are separate entities is a very old idea that doesn't seem to want to die. So we have to think about our brain as that control center. Simply recognizing if you're stuck in that feedback loop can be helpful. Looking at your thoughts and behaviors that, again, were once protective, have turned into a problem, and utilizing self-help, which is effective for some, and others may need to seek out help from a mental health professional. I would like to acknowledge my colleagues here at Northwestern in the Esophageal Center, Dr. John Pandolfino, Dustin Carlson, Iko Hirano, and Nimi Gonzalez, who helped with this research. You can email me if you have questions at Northwestern, and I am on the Bird app on Twitter at Dr. Tiff Taft. That's all I have for today. I will stop sharing.
Thank you so much, Dr. Taft. We really appreciate all the research that you're doing and the time that you took to give the presentation today. We've had some wonderful questions come in while you're giving your presentation. First, if you could talk for a moment just a little bit more about the difference between symptom anxiety and hypervigilance.
Yeah, so hypervigilance is the brain focusing in on the sensation. And if you try to direct your attention away from it, so let's say I'm trying to work on something here, I'm giving this talk, and I'm feeling, you know, sensations in my esophagus right now that I would attribute to EoE. And I'm trying to do this, I'm trying to focus on talking to you, but I'm also, my brain keeps going to, yeah, but what's going on in your esophagus? What is that? It's trying to pay attention to it. So hypervigilance is attention. And then the anxiety can follow. It's like, well, what is this? Like, what am I having an EoE flare up? What is going on? And then that what if, and, you know, thinking that this is terrible. Oh my God, why isn't my treatment working? That leads to anxiety, which is more like when we talk about anxiety and as a whole, like I feel keyed up, I feel kind of shaky or jittery, I feel tense, worried, you know, my mind might start racing, and that's the anxiety piece.
Thank you for giving some more descriptions of that. We appreciate it. So, one of our attendees today has a daughter who has about 5 foods that she can currently eat. And she said that trying new foods is particularly difficult. And sometimes she's not sure if it's the anxiety or the food itself. Do you have any recommendations for parents as well as patients to help understand the difference as they're trying to explore those things?
Yeah, that's a great question and something that comes up, I think, a lot. Not, I work with adults. I don't work with children, but in my pediatric colleagues of, right, how do we know what's really going on? And I would say if the foods have been identified as not being triggers, or they are foods that the odds of them being a trigger are very low. Things like lettuce, there's certain foods that are more allergenic, and then there's foods that are rarely a trigger for EGIDs or EoE. I would tend to err on the side of there's an anxiety component going on. But even in a food that could be a trigger, we need to try and address the anxiety component to take that out of it, right, as much as we can. So if you're able to help your child or you as the patient, I'm not worried about eating chicken, but I'm still feeling symptoms, then I would think, okay, there might be more going on in terms of this food a trigger, or is there something else that might be explaining symptoms? I will always encourage, checking in with your physician about these types of things. But if you're sure that that's not a trigger of EoE, then it's more likely the anxiety piece. And the treatment of anxiety is not wonderful in that we ask people to do things that they're afraid of. And so when I see people who are afraid to start reintroducing foods, they've scoped clear, everything looks great, we'll start picking foods. And I'll be like, all right, I'd like you to eat that. If you want to eat it in front of me, you can, or eat it at home. So anxiety, the way we cope with anxiety is to avoid it, right? We run like, nope, don't ask me to do that. And as so long as I avoid the situation that is causing me anxiety, I'll always feel anxiety about the situation. So when it comes to food, that gets really tricky. So I would teach some of the relaxation through the apps, or through help with a professional if need be, and then start working on adding the food in. All right, take one bite of that. All right, you're good for now. How'd it go? All right, next day, take 2 bites, and so on and so forth. You could, it could take a little while depending on how many foods we're talking about. Usually though, when people start having success in breaking avoidance, they kind of take off running on their own. We have to kind of get them going and get them some momentum. I hope that answered the question.
Thank you. You also talked a lot about the short form, the EHAS short form. Is that something that is readily accessible for people that they could consider doing at home?
Yeah, we recently did that where we figured out the shorter version. I can share it with APFED. I don't want to like set anything up while we're just kind of talking on a webinar. We haven't just put it out like on the internet for people to be able to download it, but it's free to use. So that could be something we could, consider making accessible in a more reputable website, such as APFED, where you take it online and get a score. That's done with other types of questionnaires out in the world. I would love for this to be readily available for people. I can send it to anyone. It's not locked down, so to speak, in terms of copyright with the university.
Okay. So if people take that test and they land in the high levels of hypervigilance or symptom anxiety, what do you recommend that they do?
Yeah, so if you went through those questions and you notice, oof, I'm a little high, I would recommend starting, so you're aware, so that's step 1. I would recommend starting with some self-help resources, an app, websites, YouTube. There's so much great stuff out there. Looking for things like cognitive behavioral therapy. exposure therapy. Those are the treatments for anxiety. And then using that resource to try and work on it on your own. And this stuff takes a little while. So we're talking 3 to 4 weeks of consistent practice before making any sort of assessment of this, if this is helpful. If after about 3 or 4 weeks of really giving it the old college try, you're like, I'm not, then I would recommend seeking out help, trying to find someone with chronic illness experience if you can. If that is not available in your area, then I would go to someone that specializes in anxiety treatments using cognitive behavioral therapy, because that's what a GI psychologist like I would do with you. So that's what I would recommend.
One of the things you mentioned was that with the help of the telehealth, that you're able to see people in more areas. Do you have any recommendations for how to work with a mental health professional over telehealth?
Yeah, it was a weird experience. We went from in person immediately. We pivoted to telemedicine last March. Everybody was like, "What's going on?" I hated it. I didn't want to do it. It makes this terrible. Now I can't get my patients to come back in the office and see me. Like literally nobody comes in because it's become so convenient, and like, you can do it on your lunch hour. It's increased accessibility like exponentially. Like travel time, Chicago is terrible for traffic. Like, yeah. But it's weird to do this over Zoom or other HIPAA compliant platform. Some therapists, if they're close, you could meet in person first and then switch to telehealth. Some people alternate, between in person and telehealth, but again, that's if you're close by. In the Psychology Today therapist directory, they will advertise that they're offering telehealth options. That's the thing they added. So then you'll be able to know just by looking at the profile, yep, they have telemedicine or telehealth. And yeah, it's going to be different, especially if you've done therapy in person in the past. But I think after, getting used to it, people are preferring it in person. So I would say try it. And if it just doesn't feel like a good fit after, again, 3 or 4 visits, then it would be trying to find someone in person if you can. But because therapy isn't going to be effective if you don't feel comfortable, and able to share and talk about things. So I have not experienced it as being a barrier, at least with the people I've seen so far.
Absolutely. So you talked a lot about how you work with adults. Do you have any suggestions of resources or places for people who are parents to be able to gather information to help their children?
Yes. I would say one thing we need to do is develop like a kid's version of that short form, right? Because there's some big words in there. You can't give that to an 8-year-old. So that's something we need. We need to push this information into the pediatric space. So until that's able to happen, I think if you're sensing anxiety in your child, our kids, I have a 6 and 10-year-old, I watch them mirror my behavior a lot. And sometimes my words come out of their mouth, which could be good and maybe not so good sometimes. And so am I exhibiting anxiety? Because I would be worried if my child, had EoE. And so if I can model calmness, if I can model using the resources, the apps and things, do it with your kid, right? They may or may not engage with you, but trying to serve as a model to take what we know in the adult space that can help with anxiety and work with your child to do it. There are kids versions of things like Calm, the app. My daughter was doing it in school. So they have a kids section of Calm, I guess. So there's definitely resources out there for kids with anxiety that could be used here. And then again, if that isn't working, trying to seek out help in the pediatric psychology or therapist space if you can. Which we have been seeing children over telemedicine as well. I'm sorry to, just wanted to throw that in. That is an option for kids in addition to adults.
That's great. So you've talked a lot about the different patients that you work with and the things to look for. If someone is going to their general provider or their GI, how can they address quality of life and things with them? And what might how might a patient broach the subject with their doctor about the anxiety and hypervigilance?
Great question. I think some of that is how comfortable do you feel with your doctor? Sometimes it's not the best fit, but that might be the only EoE doctor in the area, right? So if you feel like it's a safe topic to talk to your doctor about, you could fill out the short form and bring it in. They may not be aware of any of this research or at least the forms yet, since it's so new, and just say, hey, I took this test or this form, this questionnaire, and 13 or higher is what they would consider elevated, and I'm feeling a lot of these things. So you could use that short form as a conversation starter to say, I'm really having a hard time, like when I wake up in the morning or throughout the day, I just can't stop focusing on this, and it really is sometimes scary and making me feel really worried, and I've tried some things and I'm not able to kind of rein it in. What do you think? I didn't talk about medications for anxiety in my talk, but those are an option, especially without access to a therapist. Some people don't want to do therapy. I get it. So I would recommend some of the antidepressants out there, like Prozac, Zoloft, et cetera, it's the SSRI class, work on anxiety and depression kind of together. So a lot of times, and a lot of gastroenterologists will prescribe those medications because they use them in other conditions to treat GI symptoms because they have side effects sometimes in the digestive system. So you could pursue medication as well. I caution the use of like benzodiazepines, fast-acting anxiety medications, because they do have a dependency that can develop, and then you start needing to take more and more. So those are for when you're feeling really panicked, not for like day-to-day anxiety use if possible.
You talked about something that relates to another question in terms of how do you not inadvertently pass on your own anxiety to your children? If you're the parent of someone, do you have any recommendations, or is that not something you should be concerned about?
No, like I think I touched on my kids model my behavior a lot of the time. And so they pick up on our vibe, right? They're like, oh, mom's not in a good mood today. I was kind of grumpy yesterday, and my son's like, Mom, why are you sad? So like they feel it. So if I can be mindful of my own anxiety about what's going on with my child and use the exact same resources I talked about for a patient, those are equally as effective for a parent to try and calm myself. And if the child is having symptoms, trying to respond in as calm of a manner as you can go a long way in helping with the child's anxiety. So it's really this kind of social learning thing that we do as humans, that we're trying to intervene at that point. So you can seek out your own therapy as well if you have access, because in our practice, for example, a lot of the pediatric psychologists that we have see parents as well, or work with them together, like the child and the parent. So that could be something to work on if you go that route.
You've talked about a number of different resources and ways people can explore getting help, whether through apps and self-help resources or by working with a therapist. Are there particular self-help resources that you recommend over others?
Um, I like apps, particularly because they're portable, they're always available. Is it okay for me? I know I named Calm. Is it okay for, okay, sometimes
Yep.
there's rules. So of the apps that I like Calm. It's a subscription though, you have to pay for it, but you get a trial. I think it's like 30 days maybe. I like the app from Headspace and the app Stop, Breathe, Think. Those are really good. There is a free app called Breathe to Relax with the number 2. Super clever, right? But it's free. And what it does is it gives you like a meter with some pleasant picture, like a beach and maybe some music behind it, of pacing your breathing. It's hard to breathe slowly. Relaxed breathing is around 6 to 8 breaths per minute. The average person typically breathes between 12 and 15 breaths per minute. So you're trying to cut that in half. That might feel weird. It probably will feel weird when you first start it. So using like a meter to try, and you can kind of walk it back. So those are the apps I recommend often, even to my patients while I'm seeing them, because I'm all for technology, making this stuff accessible. And if you are working with a therapist, you can do both, together and get the most benefit.
Thank you. Appreciate you sharing those resources. So if someone happens to be going to Northwestern and they're part of some EoE or EG research, is there a way for them to get referred to a consultation with you, or is there a team that they should be referred to or asked to work with?
Yeah, unfortunately, I only do research here. I don't have any rights to see patients. They keep me hidden away in the academic offices. However, there are 3 lovely psychologists in our behavioral medicine service. So if you're here, you would ask your doctor for a referral to the behavioral medicine service. Dr. Tomasino and Dr. Pandit are heading that up right now. And you can be referred over, and then you would be scheduled with them to do all the stuff that I talked about today.
Wonderful. Well, thank you so much for everything that you shared today. We really appreciate it. It was particularly helpful and insightful to learn about the multitude of things that you can choose from, and the ability to be able to have both things that you do at home and things that you can do on your own or working with people as well. So I'd love to share some resources with people and make sure we take an opportunity to thank our education partners for helping to make this webinar possible. Our education partners for EOS Support Webinar Series are AstraZeneca, Bristol Myers Squibb, and Takeda. So thank you very much to our education partners for supporting today's webinar and the entire series. I also want to let people know about some upcoming webinars. We have another webinar on October 27th that will be talking about increasing volume and variety during mealtime. The featured speaker for that webinar is Holly Notowitz. You may have heard her speak during this summer's EOS Connections conference. She is a feeding specialist. Also can join us on November 2nd for a webinar about coping with upcoming holiday stress. We'll be joined by our featured speaker, Elisa Word. In addition, please check out our podcast. I know I just talked about Holly. Here's her picture, and you'll see her here again. We have a podcast series called Real Talk, Eosinophilic Diseases, and our most recent episode was talking about EGID elimination diets. It talks a lot about creative strategies to be able to make meal times more engaging. There was a particular part that I think a lot of people with EoE will relate to in terms of grapes being a challenging food for people to be able to eat. And I think you'll really relate to both the experiences that Holly has had herself, as well as the co-hosts of the episode. So please, wherever you listen to podcasts, check it out, or go to apfed.org/podcasts. You can also, there are so many opportunities for learning more about eosinophilic associated diseases. This summer, we held our EOS Connection 2021 conference virtually. And even if you missed the live events this past July, you can still go to apfed.org/conference And you can be able to register for the conference and watch all of the recordings from the presentations. If you are an APFED member, you can get in for free. And a nice tip, you can be an APFED member for free. So please go to apfed.org, check out our conference, and watch some of the recordings to learn even more about eosinophil-associated diseases. Another opportunity to get involved is to be able to share your experiences living with and managing asthma in childhood through the Little Airways Big Voices initiative. This is an initiative that we're working on along with the Allergy and Asthma Network, the American Lung Association, and the Asthma and Allergy Foundation of America. We recently held a PFDD meeting, which is a patient-focused drug development meeting, to gather insights about living with and managing asthma in childhood. So whether you are someone who lived with it as a child or you are helping to manage a child who has asthma, please, we are collecting written comments as well as collecting answers to a survey through October 20th. So we'd love your insights. We're going to be creating a Voice of the Patient report that will help the FDA make decisions about future treatments. So your voice would be important to be able to add to this initiative. So thank you again so much, Dr. Taft, for joining us today, and for everyone who is here listening. If you have any questions about today's webinar, please email us at mail@apfed.org. Thank you.